Good evening, everybody. Good evening. That was quick. You should come to one of my classes. I've never had people just, you must be waiting to hear Dr. Harris. But anyway, welcome. My name is Vijay Gurbaksani. I'm the director of the Center for Digital Transformation. And I cannot tell you how excited I am to see as many of you here braving the Southern California rain for Dr. Harris, who lives in Cleveland. We are wimps in the rain. We don't really show up at events, and we think this is a really bad weather day. But more seriously, you know, when I launched this center less than 18 months ago, we did it on a dream. We thought we were onto something that was important. We saw how the world was changing around us, and we made a bet. And our bet was digital transformation is really important, and the world will care. We sort of knew, we interviewed a lot of people and got the sense that companies were really thinking about how the world is changing around them. And most senior executives that we spoke to actually said something like, we know we need to do something, we don't quite know what, we need some help in figuring out what we should be doing next. So if you step back from that a little bit and you think about, well, how has the world changed? So the first computer was invented in 1951, or the first commercial computer actually at Dr. Harris's alma mater, the University of Pennsylvania. And you fast forward just 60 years later and you think about, is there any other technology that has seen the kind of price performance improvement like computers have? And then you move away from that and you think about what else is special about technology. And what is special for the first time, and I've been in this business for 28 years now, is that most of us, including in the developing world and emerging market economies, have access to computing via the telephone. We have mobile phones, we have the smartphone. So when you think about what Tom Friedman calls the hyper-connected world, you go from a supercomputer in your pocket, and let me tell you, this smartphone in my pocket is far more powerful than the computer I had to work on when I was a grad student in computer science. Seriously, right? Through wired and wireless connections to a bunch of servers, to the cloud, and all of a sudden the world is connected. And once you've got this platform, there are so many wonderful applications and innovations that you can build on top of that. And so what this has done, it's not just healthcare, it is in every possible sphere that you can think about. Mobile money, online education. You think about what the Khan Academy has done. There was a wonderful story in today's what I forwarded from the New York Times, I believe it was, to my colleagues about how high schools across the country are flipped with, you know, the word we use is flipping education, where what used to be considered homework you do at school, and what used to be considered class lecture you now do at home. What makes the Khan Academy, what makes those things possible is the fact that everybody has a computer or a tablet at home. We have the cloud, you have YouTube, and all Mr. Salman Khan had to do was build 15-minute videos explaining how to do the algebraic homework equation, right? That's the level of innovation that we need. So when you've got this massive infrastructure, then it's incumbent on us to figure out how do we leverage this infrastructure in ways that make sense and create a lot of economic value for us. So that was the vision. But then you think about how does the world change? And so companies have to figure out, now that we no longer have the benefit of a proprietary infrastructure, so if you just go back to things like the airlines, which built proprietary reservation systems like Apollo or Sabre or so on, these gave the airlines that owned those systems competitive advantage because only the big boys could play in this arena. Today, everybody can play. Right, you just think about tiny companies like Uber, which I use. Any frequent traveler knows Uber. You use the GPS app, use their app on your mobile phone. It uses GPS devices to summon kind of a black car, town car to your location. It is completely revolutionizing the way we actually travel. And all they are is an app. You think of a company called Bank Simple, and they've built an app that actually leverages banking platforms and offers you banking services. So think about a very simple application that I will mention to you, which is for those of you with families, husband, wife, 2 kids, for example, and you want to have different limits on the ATM withdrawals that your child can do from your bank account. There's not a single big bank that offers that service, well, at least not yet that I'm aware of, right? And you think about this and say, all of us would want something like that. You don't want your spouse to have less withdrawal capability than you do. That would be a recipe for disaster, right? But you may want your kid to have only $25 withdrawal on a Saturday, or whatever the case may be. These are the things that you can do with the power of software. So the world, as I'm saying, is changing around us, and companies need to respond. Moving on to the issue of healthcare. We all struggle with the healthcare system in this country. This is a perfect week to talk about this. For more reasons than one. I'm not even talking about the government shutdown, but the fact that the insurance exchange, went live. And this, whatever side of the politics you're on, is a really important development, right? And you think about all the things that we've taught about for years, how difficult technology implementations can be, the hiccups that you have when you launch complicated new systems. And here we're changing everything, right? And think about this. Would we have even been able to build a health insurance exchange 5 years ago? I'm not even going to go back 10 years. Think about this. If you didn't have the infrastructure that we did. Here's a little quiz question for you guys. When was the first online banking application built? Anybody? I'll tell you. 1983. In New York. I think it was, what bank did I use back then? It was one of the banks in New York, and I'm forgetting the name. And I was about the only fool who tried to use the app over the 300 baud line because I was a PhD in information systems. And it died because we didn't have kind of the infrastructure that would actually allow home banking. Today, all of us use home banking because we have the infrastructure. And healthcare is going to be exactly like that. So we founded the Center for Digital Transformation to say, now that we are all connected, now that we all have computing power, what does it mean for businesses, for government, for society? How do we improve the state of humankind? How do we improve the state of society using technology? That is our goal. That is our mission. We want to help U.S. companies, nonprofits, and the governments be more competitive. We actually believe very fervently that the U.S. has never been in a stronger position for global competitiveness, because what all of this requires is technology competitiveness, and in particular software capabilities that the U.S. dominates the world in. And so we think the future has never been brighter. This is what we want to foster: U.S. competitiveness, U.S. success in the corporate and nonprofit and government world. And we follow, just like kind of the business of the world of today follows an open source model. We welcome all of you to join us in this conversation to help us succeed. It used to be that research centers were insular. You gave us money, and we kind of went off and did our research. The world is moving too fast for that to happen. The smart ideas are everywhere. The smart research questions are everywhere. We need to accelerate the translation of ideas into practice far faster than we've ever done before. All of this means that all of us have to work together to help our communities, our country, our society be more successful in the long run. So I invite you to join all of us in this journey. Let me do a couple of housekeeping announcements, and I'll turn the floor over to why you're actually here, to the panelists and the speakers that you want to hear. So first, we are recording the session, and most of the recording will obviously be focused on the speakers, but if you do have any objections to, in case you ask a question being recorded, please let my staff know, the people who are sitting on the outside, and we will delete your comments from the recording. We do have evaluation forms on every chair, so I would like you all to kind of complete that when you're done, because feedback is a very important piece of what we do. This is the fourth. So this is what we call an idea exchange. We have 3 to 4 a year on given topics. Our theme for this one, obviously, is digital healthcare, and our audience has grown with every single event. So thank you so much for honoring us with your presence on, like I said, a rainy day. It means a lot to us that you take the time to attend our events. We hope that means we are giving back a little bit to kind of helping us all get better at our jobs, helping us understand how to navigate kind of a complex world in front of us. There is one person I want to thank before I leave the stage, and that is Sam King, who is the event chair. He is our industry fellow at the Center for Digital Transformation, who runs all of the digital healthcare events from us. You will hear from him at the end of today's session. With that, let me kind of make a couple of introductions. I want to introduce our moderator for the evening, who is Ryan Witt. He is the Global Managing Director of the Healthcare Industry Solutions Practice at Juniper Networks. Juniper, as you know, is one of the largest networking equipment companies in the world. And it's kind of interesting how, the healthcare industry, the healthcare sector has become so important. It is, a huge of societal concern. It is a financial challenge for so many companies, and it is certainly a financial stressor for so many individuals and families, that more and more companies are actually launching verticals in healthcare, because this is clearly kind of not only an industry with huge demand, but it's an industry that demands great solutions. And I think it's very kind of insightful of Juniper to focus on this sector, and we're delighted that Ryan could be here with us today and help us moderate the panel. He's got a long history in the healthcare industry, primarily with technology firms other than Juniper, but prior to that with Xerox, Hitachi, and Bridgehead Software. So Ryan, thank you very much for your support of our center, and thank you very much for agreeing to moderate the evening. And Ryan will come up here shortly after the keynote address. It is also my privilege and honor to introduce Dr. C. Martin Harris as the keynote speaker for the evening. Dr. Harris, as you know, is the Chief Information Officer and Chairman of the IT Division of the Cleveland Clinic in Cleveland, Ohio. Where else would the Cleveland Clinic be? Actually, they have many locations. He has a long history in this, and I could read the bio, and I don't want to take up too much time, but there are very few pioneers in this space who have focused on really transforming the practice of healthcare, the delivery of healthcare services, the practice of medicine through technology. And we see more and more people entering the space now. But, when you look at the foresight of the people who entered the space before it was sexy, and kind of played the kinds of leadership roles that Dr. Harris has played, we're just absolutely honored to have somebody with his talent, his experience, his know-how to share their expertise with us. I'll just say a couple of things. He's past chairman of the board of the HIMSS Healthcare Information Management Society, appointed to the IT Standards Committee of the Department of Health and Human Services, the Health IT Standards Committee, former advisor to the director of the National Institutes of Health, congressional commissions, and so on. The one I noticed was the Commission on Care for America's Wounded Warriors. That's a presidential appointment as well. This is a gentleman who has given an amazing amount to our country and to society and has an amazing amount of experience on the issues we would like to hear more about. With that, Dr. Harris, welcome to the stage, and thank you so much for taking the time to speak to us.
Great. Thank you very much, Vijay. Can everyone hear me? Okay, great. So while we're getting this set up, I first wanted to express my thanks to Vijay and Sam for inviting me here today and making me really feel at home. And I think Sam went well out of his way to produce the weather that looks just like Cleveland outside. So with that, I really wanted to do three things with you today. And I think it is an exciting time in healthcare, but it's challenging. But I think great challenges make for great differences, and great differences make patients' lives better over time. So I wanted to do three things, and the first one is really to build a framework about how we think about healthcare reform. And as was mentioned earlier, I really don't think it matters what side of the divide you're on. We have a fundamental challenge, which is delivering value to patients that we serve every day. And we are going to have to do it differently. Now, I think everyone knows that over the next 15 years, there's going to be 10,000 Americans every day qualifying for Medicare services. Now, we cannot meet the challenge of caring for all of those individuals if we have the same model of care that we've had for essentially the last 250 years. We'll have to do something differently. So the second thing I wanted to do is to talk about, if we imagine that different, that transformed delivery system, what tools might we need in order to make that leap? And then finally, I want to end by sort of taking those tools and tying them together into a story that might help us both envision what that delivery system might look like. So I'll start with a simple framework for the healthcare challenge, and I think everyone has heard about it in one shape or form, and it's really this journey that we're on from paying for volume to paying for value over time. And about 3 years ago, we had the opportunity of hosting the President of the United States. It was kind of right after the height of the question of access to care. And really, our conversation with him was really focused on, once we have, as is happening right now, 40 million more people eligible for the healthcare system, now what are we going to do? And the answer is that we've got to do a number of things really well. The first thing is that we needed to focus on quality. If we add 40 million people and allow the quality of the care to drop, we have not provided a service to those individuals or the ones who are already in the system. So if we don't do it in a reliable and safe fashion, it doesn't matter that we get it right once every 10 times. No one would want a service like that. Now, the third one I think really is the big challenge for us, and that is this concept of care coordination. That as we go forward over the next couple of decades, it's clear that the complexity of care is going to rise, and where we need to deliver that care is also going to change, and who's involved in the healthcare team will be far more complex than it is now. So that we are likely to have clinicians, nurses, other allied health professionals that are part of an individual patient's care team, assembled by that team, by that patient, probably through their payer, to provide that care, independent of where they are currently employed. So care coordination, to me, is fundamentally driven by the value that we can bring through health information technology. It's the tie that binds those care providers together and keeps them focused on quality and safety going forward. And then the last point I would make is no matter how good it is, if we hit the top three, but it is absolutely unaffordable by the typical average American, then we've not delivered on the value equation. So I think if you keep that framework in mind and really not worry too much about the current battles that are going on, no matter what policy we're following going forward, we've got to deliver on these four things or that policy will not be successful. So the second point then to me is really starting to think through what tools are we going to need to transform from volume to value and to deliver on those parameters. And so what I wanted to do was to use the Cleveland Clinic just as an example to try and describe how those tools might work and to sort of set a common ground with everyone in the room about what this technology looks like. So for those of you who don't know the Cleveland Clinic, it is an academic medical center created in 1921. It has an employed model for the what we call the main campus operation, which is a 1,300-bed inpatient facility and about 1,200 specialists who practice in that one location. It's distributed in a series of family health centers that go from essentially large doctor's offices to facilities that have freestanding emergency departments and ambulatory surgery centers attached to them. So near hospitals, but not really hospitals, all doing ambulatory work. And in these two locations, the physicians and all of the other caregivers are employed by the Cleveland Clinic. Now, over the last 10 years, we have acquired a number of hospitals because we needed facilities that were closer to the patients in order to deliver inpatient services, and that's what these blue H's are. So from one side of that screen to the other is a little over 100 miles, and from the top of it, that's the lake at the top, to the bottom here is roughly around 50 miles that we're trying to cover and deliver care to well over 1 million patients that we serve on an annual basis. Now, there are a couple of standouts here. Down in this far corner is the Cleveland Clinic, Florida. So it operates in exactly the same way, but it's a mini version. Think of it as about a tenth of what's operating in Northeast Ohio. There is a facility that we operate out in Las Vegas as well. And then up here somewhere there is the Cleveland Clinic, Toronto. And you may have heard that we are developing the Cleveland Clinic Abu Dhabi, which is roughly 7,500 miles away. Now, what's key to delivering on the promise of care across this kind of continuum is fundamentally rethinking what we mean by care delivery and how we do it. And so to that end, about 10 years ago now, a little more than that, we began this journey about thinking around what health information technology could do to change the practice of medicine. And we were really thinking about it in the heart of medicine. And so as we devised our quote-unquote IT strategy, I'm really not a big believer in an IT strategy. I think we have a business purpose and we have a business strategy, and then we have technology that enables that strategy. It can accelerate that strategy. It can transform that strategy, but it's not distinct from the fundamental purpose, which is delivering great care to the patients. So we developed this mechanism that we called eCleveland Clinic, and it was designed to envision a different way of caring for patients. And as we thought about the internet, We thought about the idea that we could run to the front and be a great content provider and everyone would come to the Cleveland Clinic site for information. But at the end of the day, we knew that we wouldn't really be a leader in that space over time. We provide a lot of content. We share it with other sites on the internet today. But we came to the conclusion that the key for us and around the internet was really thinking about providing services in new and novel ways to patients going forward. So that was the fundamental tactic that we focused on. So eCleveland Clinic is the virtual concept of the Cleveland Clinic operation, but it was designed to meld all of those fixed facilities with other opportunities that the technology presented to us, and to try and make it one, and to try and make it seamless to the patient as we move forward. So what I want to do is to sort of walk through what we've been doing and use this as a framework for describing the tools that I think would be necessary to actually transform our healthcare delivery system. And I'll end with a very quick story that's how to tie these things together. So the one that I think everyone in this room would recognize at this point is the effort that the healthcare industry has put on deploying the core tool, which is the electronic health record or the electronic medical record. So for us, that tool is really central to thinking about the practice. So we have a couple of unique definitions. So the first thing for us is registration, scheduling, insurance management are all part of a clinical system. Many people think of those as separate. In our model, they absolutely are not. They are directly tied to all of the other clinical things then, placing an order, seeing a result, writing a note. We think of all of those things as part of the electronic health record. The second thing is we absolutely think that the patient needs tools if we're going to move forward as well, and we wanted the patient to be using the exact same infrastructure as the doctors and the nurses and the registrars going forward, because we knew if we were going to innovate, we wanted people to be working in concert. And then the last is we have a mission of both education and research, and so we wanted our trainees, the residents here, and our researchers to be able to access and use that very same tool to drive medical knowledge faster through the use of this technology. So our definition of the electronic health record or medical record includes all of these individuals, and the key to us was that we wanted them to be using the exact same database. We didn't want to be spending a lot of time trying to figure out what data set someone was actually using. So we built a core strategy that says, as we built out this tool, at the heart, the core things, ordering, scheduling, identifying a patient, we wanted one database to manage all of that. So when you think about it today, as I mentioned earlier, we employ about 3,000 physicians across our enterprise, so the difference between 3,000 and roughly 8,000 here are the privately practicing physicians in all of those other hospitals other than the downtown campus. So it's just reverse. When you're on the downtown campus, it's an all-employed model. If you're in any one of those other blue dots, most of the physicians are in private practice. But our standard is if you practice in one of our facilities, then you use this information tool because you're part of a shared care team for the patient. So the 5,000 or 4,000 additional patients that you see, physicians that you see here, are in private practice, but they're using those same tools, and that sets us up to work in a more collaborative way. All of our trainees use the tool from day one, whether you come in as an intern, a resident, or a fellow, and all medical students start using this tool within the first month of arriving at the facility. Now, it is the core of what we do today, so every day at roughly 10:30, 11,000 people hit the enter key at exactly the same time. This is now part and parcel of the practice of medicine for us. It's not on the sideline. It's at the heart of what we do every day in caring for patients. Now, just to make sure we're all talking about the same thing, as we talk about an electronic medical record system, this is the ambulatory set of components. So it does messaging, it shows you an integrated schedule. That's why we think of scheduling as being clinical. And you'll see that we use the schedule for lots of things to drive clinical activity. Results for us are results. We don't talk inpatient results or outpatient results. They're simply performed on a patient and they come back to their record. If you want to know where it was done, it's very easy for you to see that in the system. All of our documentation is done online. This has probably been the longest journey that we had. So the first 3 years was just put it in anyway. Type, talk to it, do whatever you want. Just get a note into this computer in some way. At this point now, we've moved to a very structured model of documentation because it gives us discrete information that we can act on. But if you're really coming from paper, you probably will follow that same journey. You probably will be able to shorten it a little bit. For us, that journey has taken roughly 8 years to get to the point where we can actually drive predominantly discrete entry. It is computerized physician order entry everywhere, ambulatory, inpatient, it does not matter. And then the power of the tool comes in these best practice alerts. So we can take the knowledge that's collected in the 3,000 physicians and begin to deploy it through the computer technology to every patient who's coming through this facility so that we can drive alerts and enhance the quality of the care that we're delivering. And then the final thing I would say is, as you listen to EMR and EHR descriptions, people talk about imaging as if it is something separate, and it absolutely is not. Historically, imaging has been about, tell me about that particular organ and whether it is physically intact or in the right place. But that's a very old way of thinking about imaging. Imaging today and tomorrow is really not only going to be about anatomy and location, but it's also going to be about whether or not that organ is actually functioning in the way you would like it to. And there's a lot more information that comes when you start to think about it that way. So as we began to think about this, it became clear to us that imaging had to be part of the electronic health record concept, and that for the average physician in the institution, our goal is for them never to know the name of the imaging system. They should simply think about it as the electronic health record. Now, on the inpatient side, I'm not going to spend as much time on this. It's essentially the same system, same database. Instead of thinking about the schedule, we're thinking about where the patient is in the bed. We collect a lot more information around medications. It's barcoded med administration, so I know exactly who gave it, what time, what floor, what location, what device, and whether or not they took it at all. I have their vital signs. The documentation is the same. It is computerized physician order entry, and it's the same imaging system as well. If you haven't seen it before, this is an approach that we have to imaging today. So this is the electronic health record, but our goal was to make sure that a browser window didn't pop up over top of this, that our goal is to make sure that if you want to see a chest x-ray, you can see it, but you still have direct access to the electronic health record, because if this showed a pneumonia, the next thing you would want to do is to go order an antibiotic, and the last thing I want you to do is to have to close that window and then go back to the electronic health record to care for this patient. So that is the sort of framing tool. I consider it the building block of getting to a transformed healthcare system. And for us, we've been at this now to the point where we have e-enabled the entire enterprise. So it is the same system whether you're in Nevada, Florida, or Cleveland, or Toronto at this point in time. It even deals with time zone differences through the scheduling and makes all of that work. So before a patient could get in a car, or if they're in Nevada, get in a plane and make their way to another one of these gold dots, what they now have is the expectation that the next clinician who's going to see them has all the information they're going to need in order to make the best clinical decision for them. But that alone does not get you to a transformed healthcare system. So as we were thinking about this concurrently, we knew that we had to engage patients and bring them along the way. So in 2003, we began one of the early deployments of a personal health record system. Since we were in an academic medical system, we had to study it first, so we did it with 3,000 patients for about 2 years. It drove me crazy. But the good news is now that we have widely deployed this tool. So what is it? It is a personal health record that's tethered to that same database, so patients know they're looking at exactly what their physician is looking at. Medical information is just that, real results, real orders, real documentation. Reminders are just those alerts turned around and presented to the patient. So here's a hint, it's time for your hemoglobin A1C. It's coming automatically, it's being delivered by a computer. There's no human intervention for those kinds of things, following the rules that our physicians have written. They see the same schedule we do, and we can use the schedule to drive lots of reminders. Prescription renewal is the redistribution of work at one level and an engagement tool. So our patients do not have to call the office. They can initiate a prescription renewal online. And now they can make, if they have an established appointment relationship with a physician, they can make a direct appointment and know that it's booked at the time that they click off. We also knew that it wasn't going to stop there, and as was mentioned earlier, I believe that the sort of generic tool, the one that ultimately binds the patient to the healthcare system and makes them feel engaged 24 hours a day, is something that's going to be with them all the time. And some technology like this is what I'm imagining will help to do that. We do a subset of what we do in that personal health record through this online tool today, and there's an Android version of this as well. So when you think about that tool, we've gone from that study of 3,000 patients using the tool and understanding how it works to last October, we crossed over 500,000 patients. And at that point, we flipped the model and we made it our standard of care. So when you come into the Cleveland Clinic today, we no longer ask, would you like this tool? This is very useful to you. We begin with, this is an expectation. We can give you better care if you use this tool. So they are automatically presented with an access code with the assumption that they will want to use it. Now, they can always reject it, but by changing that attitude, engaging the physicians in it, we were at 500,000 users last October, and as of August, we were at 900,000 users. So this is now the standard of care at the Cleveland Clinic for anyone who has the ability to access these kinds of services. Now I wanted to sort of walk forward again and talk a little bit about some other tools that I think are going to be necessary if we're going to transform care. So the first one I would say is that we're really focused in on this idea of monitoring. So really understanding what's going on with the patient right now. So real-time monitoring. And so we have two levels of service that we provide. The first one I call the high-end version. And this is really related to implanted medical devices, which are computers that have wireless access capability today. So this is the high-end version of a pacemaker. We can do the same thing for a brain stimulator for patients who have Parkinson's disease, and the same thing for a patient who has the fancier version of an insulin pump. And so basically what we want to know, when you put in a device like this, it's a little bit like putting a part in a car. It needs maintenance. You got to take your car in 4 times a year. Someone should be looking at that device 4 times a year. And historically, that meant coming down to some facility to have it checked out. So we now offer our patients two levels of service: traditional, which is that four stops a year, or what the physicians have now taken to calling the OnStar version. So the OnStar version is 3 times a year, you do it virtually, and once you come down to the office. And essentially, they go home with a very small instruction kit, and they load a piece of software onto the laptop, and then there's a window, so they get an email message through that MyChart system, and it says anytime, 24 hours a day, over the next 2 weeks, invoke that software application and send to us the information that we need to assess that device. It gets picked up, it crosses the internet, it comes into the EMR, But the most important thing for us is it goes to the location that the cardiologist is going to look at it, and it's in that same tool with their meds and their labs and everything else. They're not going to look somewhere else in order to get this information. So that's kind of the high-end version. The low-end version then really relates to other tools like the glucometer that you see here, but a pulse oximeter, scales, blood pressure cuffs. We're beginning to connect all of these things remotely from the patient. So these are all consumer devices. We don't buy them for the patient, but we make it available for the patient. So a routine blood pressure check, if the patient invests in this tool, they used to have to come down to the office, or our convenience model used to be you can go to any one of those gold dots and have your blood pressure checked, and it'll end up in your electronic medical record. Our new version is if you have this device, you don't need to leave the comfort of your home, and you can have your blood pressure checked. So these tools have all been e-enabled, and they pass the data, again, back into the electronic health record. We have applied a series of rules, because you can imagine the volume of data that's now coming back, and we use the power of the computer to sort it out between those things we need to see right away, those things that are in the box, and we can send back an automated good work message and something that someone else might need to see and think about. So the other piece that I would say before I wrap this up with a story that tries to tie it all together is that as you think about those tools and think about how they work together, one of the things that is clear is that interoperability is probably the last great challenge that we have. That whole story that I've told up until this point has been very Cleveland Clinic-centric. I've just been allowing you to get away from the main campus facility, if you will, and to do more and more in your home. But the central focus is still Cleveland Clinic. That is not how medicine is really practiced. And I'm a general internist, but I do mostly preoperative medicine. And I can tell you virtually every patient that I see has picked their care team, and it has a physician who's not employed by the Cleveland Clinic, 2 or 3 physicians that are employed by the Cleveland Clinic, a physical therapist that's employed by a totally different organization, and that patient thinks of that as their care team. If we're going to make that group work together, we need to get to this idea of interoperability in a seamless fashion. So one of the projects that we worked on about 3 or 4 years ago, which is now a commercial service, is that the idea that it's called Health Vault here, but it's essentially a health information exchange. Now, we don't want to get into this business because now we're thinking about making connections for 300 million Americans is a little bit beyond our appetite. So what we wanted to do was to find a partner who was willing to work at that level. And we did some work in the same vein with Google as well, but these are companies that are used to dealing with hundreds of millions of individuals every day. And so what we did with them is to say, get us out of the plumbing business, if you will. And in that back end, home devices, physicians' offices, hospitals, I want a service to go out and do that plumbing connection work. Now, there's sort of 3 ways that I imagine this will play out, and I'm not exactly sure which one's going to be the winner. But there's a federal model today that's called the InWin. There are state models for health information exchange going up in all 50 states, at least 1 in every state. Some states have 4 or 5. And then the last one are private sector models, and I think right now Health Vault is one of those examples, but I would expect to see the telecom industry come into this space and probably 3 or 4 other infrastructure companies. I've heard banks that are getting interested in this as well, and tying it to your understanding of your financial responsibility. But if we can get the right groups to do this work, what we can do then is have the healthcare providers make one connection to that switch and pull the information back into that electronic health record that I began talking about. And then once it's there, I can make it available to the physician who would see that patient. Even though they've never set foot in the Cleveland Clinic, they're now actually acting on real clinical information. So I've walked through some of the tools, and I think there were 4 or 5 others that I could walk through, but this story really is about what are we going to do with those tools? How will we actually transform the delivery system, and how will we get it to the point where we can meet those quality, safety, care coordination, and cost challenges that are in front of us? So I just wanted to end with a quick story that kind of ties all of those things together. And everything I'm going to show you is currently operational at the Cleveland Clinic, with one exception that I'll point out when we get there. So here's a patient in the southwest United States. They have a major cardiac condition. They've already seen a physician who's given them the diagnosis, and they've been recommended to have surgery. So in this case, the patient makes the decision that they want to get a second opinion from an expert in the area related to their diagnosis. So second opinions are very common for high-end medical conditions, but in this case it's different because this patient actually wants to get that second opinion from a physician in the Cleveland Clinic. So what they do is they actually go online, and one of the tools that I didn't show you is a tool that's called My Consult. And My Consult is an online second opinion program. You simply go on, access the service, put in your primary diagnosis. It brings up a series of questions that have been designed by our physicians. You fill that out, and then it tells you exactly what information you need to collect. And instead of taking that information across town to a physician for your second opinion, what you can do is express mail that information to the Cleveland Clinic. There's a service there that's waiting for your package. They take it in. It's a nurse that receives it. Once they know that it's complete, they schedule it as an appointment. The doctor's upstairs going room to room to room. They go into the next room. There's no patient. There's what we call the pizza box. In the pizza box is all the information that's required to perform that second opinion. And if you see the pizza box as one of these subspecialists, you know it's a complete consultation. So again, one of the other things that I do is I see patients who actually decide to fly in, and I can tell in the first 5 minutes that they didn't have the right information with them at the time, and there's a whole bunch of other testing that would need to be done before we could render a professional opinion for them. So this model actually turns it around the other way and ensures that the information that's required is available for the physician to render their expert opinion. And when they're done, they can send that information electronically back to the patient. And then we also reverse the process. So in this case, the patient gets that consultation. We give them 2 days to go through it. It's annotated. And 2 days later, we call the patient. So now they are equally as informed as the physician who they're going to talk to, and it really straightens out that communication process. My big challenge is if I do the same thing on site, I will see the patient at the end of that day. I'm talking to them, and I can see right away they're getting about 25% of what I'm telling them. They go home, and then the telephone starts ringing. So this is a transformative process. It empowers the patient. They're far more knowledgeable when they go through this model, and they're much more actively engaged with the clinicians when they're talking about the decisions that need to be made. So in this case, the patient decides ultimately that they want to come to Cleveland because the surgery is relatively complicated. So what we say to the patient is, before you come, we want to make your visit as efficient as possible. And so in order to do that, we'd like to know more about you than maybe we received in that consultation. So we'd like you to go sign up for one of those HIE services. And at the same time, we want you to sign up for another service that I didn't show here, which is called DR Connect. So DR Connect is a web-based service that allows any physician in the world who is identified by the Cleveland Clinic to gain access to a patient that they refer to the Cleveland Clinic. So those are the only patients they can see, are their patients that have been referred to Cleveland, but they simply go online, click a button, and all their patients that are active at the Cleveland Clinic are available to them on a screen. So we would ask this patient to sign up for this service and also sign up the physician who's going to care for them over the long haul for that DR Connect service. Now, when they sign up for the Health Vault, now what they do is they actually get their own account. It's under their control, and they can pull the information into that account and load it into the record. Since the patient controls it, now we avoid all of those HIPAA challenges. And what they do is they sort of build a pointer, if you will, and they can then make the decision that they want to transfer that information right into the Cleveland Clinic. For us, it maintains workflow because it actually goes into the same EHR that the doctor is using for everything else. So now we have a patient who's never been to Cleveland, for which we're confident of the diagnosis, for which we have the additional information, and if there was something missing, we can get it fixed while they're still at home, where it's going to be a lot cheaper than if they arrive in Cleveland, and on that first day when we have the operating room scheduled, we figure out that, in fact, we're going to have to delay the surgery. If you delay the surgery, there is no way to recover the cost in that process. You have a fully staffed OR. So eventually the patient is ready to come for surgery, and you can't stay at home for surgery, so eventually you're going to have to make your way over to Cleveland. But when they get there, they are cared for by a physician who's using that electronic health record. Since we signed up the local physician with that DR Connect service, while the patient is at the Cleveland Clinic, from the first time they hit the first registration desk, for every other transaction that happens, their physician back in their hometown sees all of that information and can be a virtual participant in the care. If they were expecting something else to happen, they can make that communication happen while the patient is in the facility. Now, eventually things will go well and the patient's going to go home. So we sign them up for that MyChart service, because now when that patient thinks about their healthcare team, they have some physicians in Cleveland, they have some physicians at home, they have some information in Cleveland, they have some information in their hometown. And so we want them to sign up for that MyChart service so that they can maintain contact with their virtual team back in Cleveland. Now, this is the part I made up. So we sent the patient to sunny Florida to recover. You can't recover in Cleveland. The sun never comes out. And so they're on the nice beach there recovering. But if you're post-cardiac surgery, there are some things we want to know about you right now, every day. So one of those things sounds simple, would simply be what's your weight and what's your blood pressure. And we'd like that feedback because I'm going to adjust your medications post-operatively, but there's no reason for you to be in Cleveland in order to have those things done. So finally, the patient's going to make their way home, and when they do, here's the difference. The first thing is that that patient can expect that they have maintained the connectivity of their defined healthcare team, Cleveland Clinic physicians and physicians in their local community. The second thing is all the information, because that Health Vault button works both ways. When they're done, they can turn it around and take all the information from the Cleveland Clinic and move it to that Health Vault account, and then move it into a local EMR in their local physician's office if they like. So now they know that they have access to the information that they need, and it allows us then to get to this image that we've always had of patient-centric care, but it's patient-centric care that can only happen in an E-enabled, transformed healthcare delivery system where we're using the technology and all of our clinicians to fundamentally focus on the patients and their needs. So let me just end by saying, in order to get to a transformed healthcare system, you need the tools, and we've talked a lot about that, but we also need to engage the patient and really make them an active participant in the care. By using these tools, we can empower them to give them the right information, to give them the tools to also assist in making the best healthcare decisions. And then finally, structurally, as we think about the millions of Americans who are going to be older than 65 and require healthcare services going forward, we have the opportunity, using this E-enabled model, to be able to begin to deliver care to all of those individuals to change the setting of care to settings that could be far less expensive, like the home, but to absolutely be certain through the management of information that we're holding to that standard of high quality and great safety. Thank you.
Thank you very much, Dr. Harris. That was amazing. Initially, when BJ talked about framing up the idea exchange, and thank you very much for allowing Juniper to play a role today. I think what you created here is amazing. You talked about flipping industries, and you used two really good examples. Uber is doing wonderful things in transportation, and Khan, of course, is becoming, I think, the poster child about how you flip an industry. I think if we see this sort of use case example that was outlined by Dr. Harris, maybe we could add Cleveland Clinic to that list, because they're also really doing wonderful things there. You also made reference, Vijay, about why there are a lot of technology companies taking great interest in healthcare. And of course, there's a financial motivation for that. But I think the reason we see this significant investment from the tech community into this vertical space is that we see that the reality is that the technologies that are prevalent today, that are used very commonly in other industries, that are readily available, can be applied to healthcare. So if you look at what the Uber example was, which ostensibly is an app, okay, with some analytics and some databases behind that. You look at the Khan Academy example, which is just online courseware, so it's heavy use of telecommunication technology. It's the application of that technology can really help transform healthcare. So I think that is the interest that the tech community has in this space, is that we're not waiting for new products to be developed. We're waiting to bring products that are currently available to this marketplace and go help with that transformational journey. So tonight is about an idea exchange. And so the way the panel is going to work is we're going to spend about 30 minutes or so talking about some ideas, sharing some thoughts with Dr. Harris and also Orlando Portale. So Orlando is the Chief Innovation Officer at Palomar Health and also is the founder of Glassomics.
Close enough.
Close enough. I'm sorry. You trained me on that too. Glassomics. You trained me on that too. So we have two really interesting sort of perspectives that I want to really talk to them about. And then I think we'll have probably 30 minutes or so to open up more broadly for questions from the audience. So to get really the ideas flowing on the panel. And I guess the thing about healthcare is it's never in the news. So feel free to make some news tonight. Let's see what happens here. So I guess throw this first question out. You painted a very real example of how you can apply technology to a caregiving setting and make demonstrable differences by using at-home-based technology. I guess the reality is, for many other hospitals that I personally visit, and I'm sure that you had exposure to, the type of infrastructures they have in place today probably resemble the computers that were invented at your alma mater. So how realistic do you think it is before this sort of caregiving scenario will be prevalent across the country?
So it's a great question. That story is a long journey. It's
Sure.
a decade's worth of work. But I think, like in many other industries, what we're going to see is bringing scale to the problem. That what we shouldn't be doing is solving the problem 5,000 times. There are 5,000 hospitals in the country. That we have to get to the point where these become services that are available. And so we're beginning to see those things work up. And I think you'll see it in two ways. One is in services that you can simply go out and buy that core set of technology and have it provided. Now, it's not as simple as going down to the corner store.
Sure.
But by the same token, I think it absolutely can be a hosted service. So we are now doing that. outside of our region, so we will provide the service. It's the exact same set of tools, tailored to the size of the hospital, but they never have to build a data center, they never have to acquire the equipment, and it's delivered pretty much as a service. So my expectation is that those will really come to fruition over the next 3 to 5 years. And I think the other is that there will be consolidation in healthcare as well.
Right.
That I think what we have done historically to meet the healthcare need is to build more and more facilities and take the healthcare closer to the patients, which was good when the services that we needed to deliver inside of those hospitals was not that complicated. But today it is, and you really should be willing to travel in your local community, travel more than, we've been built around this idea that you should only travel 4 miles from your home, but if someone's actually going to take your heart out and put another one in, you probably should be willing to travel a little bit further than
Unless
that.
it's raining, of course.
Yeah. And so what I imagine is you'll see some consolidation of hospitals, and with that scale, you will also get the ability to drive there. So I think this is a work that will now happen in a much shorter period of time over the next 5 years, and it's going to be driven by a lot of the activity that's been happening right now, the investment in meaningful use and those kinds of things.
Yeah, I think we're definitely going to see a lot of consolidation. Fortunately or unfortunately, I think we're going to see about 20% of community critical access hospitals go the way of the Twinkie. And whether they're going to go out of business or get acquired is basically the option at this point. So the Cleveland Clinics of the world are probably going to go on a acquisition spree, if you will, and buy up hospitals, clinics within their catchment area. The affordability of a lot of the solutions that I'm seeing that are being brought to market, and even those that are being developed that are funded through the venture community, a lot of startups, and that's primarily the world that I deal in, is the startup sort of world. There's a lot of innovative technologies being developed for the healthcare space, but unfortunately many hospitals today aren't in the position financially to acquire those solutions. So the ability to drive cost efficiency, I think, is going to be top of mind for those folks in the tech audience here that are doing startups. If you've got something that drives clinical efficiency, operational efficiency, that's going to be top of mind in terms of hospitals buying solutions here going forward.
So one of the things you focused on, Dr. Harris, in your presentation was the importance of the EMR and making that digitized patient record shareable widely. And of course, when you have within a Cleveland Clinic sort of scenario, that's very easily achieved. Well, it's more easily achieved. Of course, it's still a long journey. But you get into a broader context, and then you're bringing in competing healthcare entities or community hospitals, you're bringing in the VA, et cetera. How realistic do you think it is before we will have a widely available, portable patient record that's not in the form of a DVD or something in a manila folder?
Yeah. So I think if you just follow the meaningful use program, I think that the adoption, so first you have to get adoption of the EHRs, and I really do think that window is going to look something like 2018, that most facilities will have it. I think the second stage then, to me, if we're going to get to a transformed healthcare system, is we have to get to interoperability. Now, I will tell you, I think the adoption program is going pretty well. I think the interoperability program is a little behind the pace that I was hoping. But I think this is where innovation plays a real key role. You will notice that we haven't placed a bet. I'm not certain where the solution is going to come from right now. And I think it's equally likely that it will come from the private sector as it will from the public sector. The idea that the big telco companies, the banks could provide interoperability at a unit cost that's affordable by a typical healthcare system is not too far off in my mind.
So you refer to the banks. Do you mean the payer community, health plan community, or do you mean more traditional banks?
I mean literally the banks. If you want to get real efficiency, you should use the infrastructure that already exists, because their marginal cost to expand to deliver transaction services is pretty small. They're already doing it today. So that's why I'm saying I don't know where it's going to come from. I think it's going to come out of left field. The three plays that I see right now are federal, state, and some private activity. Sure. I think the private activity is going to grow dramatically. If that works, and we are still looking for a home run here, is what I would say. I haven't seen it yet, so I think that one's a little further out on the time horizon. And I think it needs more investment and more focus from an innovation point of view.
Orlando, what's your point of view?
Well, the problem we have in the U.S. is it's being dominated by two electronic medical record vendors, Epic and Cerner. And given the competitive nature of that business, there's a lack of willingness to cooperate in full interoperability. And that's been a barrier historically, and I think that's going to be a barrier going forward, unfortunately. If you had the banks step in as a intermediary or a service, if you will, that could host a number of solutions and that could provide some interoperability, they would still need to deal with those legacy vendors that we know all too well, and that might be a challenge.
What about the proprietary nature of some of their systems?
They are.
Is that
very proprietary, very old technology base. And some of the vendors are a little more open in terms of allowing you to innovate around the edges, if you will. Others are less so, and others generally deliver a vanilla solution to the customer, the hospital customer, the healthcare system, and don't allow a lot of edge innovation. And so it's a big challenge. A lot of the startups that I see are trying to innovate around the edges in medical device space, wearable devices, genomics, some of the other edge areas. And then when they look to do integration with the EHR vendors, there's generally some difficulty. And that's been a roadblock for the industry and a roadblock for a lot of the startups looking to go to market.
One of the things I'd say, though, is if you think about it, 20 years ago, I wouldn't have thought of banks as being innovators. Right? You still went into the bank, sure. You still feel. Now it's pretty amazing when you think about it. But I had a chance to tour a local bank, a pretty big regional bank. And when I got inside the data center, I can tell you there's not a lot of innovation inside the glass walls. It's the same old mainframe system and database systems I hadn't read about in years that are actually running your accounts today. But I think what's different is the customer demand for that edge innovation. And that if we can drive a system where the customers demand it, the providers of the technology will respond or they'll be eclipsed. One example, when we announced the Health Vault connection, our core vendor drove that process. And it was important to them because it begins to reflect on the tool.
Sure.
Right? And so I think if the more use cases we get where we can show clear innovation, the more likely we are to drive down the edge process.
So let's talk about the banking industry as a comparison to healthcare for a second, because you're right. They're not known as a bastion of innovation, but yet I think in the space of 5 years, most of us probably don't go to the bank too much anymore, right? And so clearly they have used innovation in a very powerful way. That opportunity exists in healthcare. You certainly showed it. How long will it be before we're not going to be visiting our primary care physician or our local clinic in the same way we don't visit the banks anymore? How long is that away?
Yeah. What I would say to you is you're always going to see a physician. I think the question is, are you using the right tool for the right problem? And so there's a lot of things that we do today, a simple blood pressure check, checking the glucose on a patient who has diabetes, that is actually happening in a physician's office, and it absolutely does not need to. So what I'm suggesting to you is that as we get this flood of patients coming into the healthcare delivery system, it's going to force us to rethink that. And so what I would say is, look, if you fall off a bicycle and break all your bones, you're going to see a physician.
You're going in.
Okay, you're going in. But why should you have to go in simply for a routine check of something that could be done remotely? I think that's where you're going to see the big change coming. And I think as the technology advances and you can see and talk to someone relatively easily, we're spending a lot of our time right now working on that basic, what I call the human interface, to make it as natural as possible. That I think the more of that we can do, the more things we will be able to do remotely. So I don't think it's a when will it completely go away. I think what you should be thinking about is a mix of services. And today it's 100% go to the office. And I think it's going to turn into a 40% of the time I can do this from the office or from home or even on the road in a hotel. And 60% of the time I have to do something else.
Right.
And I think long-term we're going to see wearable devices, implantable devices that will allow us to be much more proactive about deteriorating conditions, about managing chronic disease conditions in a remote sort of setting. And that's really, I think, where the future is and an opportunity to potentially drive down costs.
So I want to come on to wearable devices in a second, but I want to ask one more question about the kind of, I guess, the juxtaposition between the current model and then moving to the value model. Because we can see this, right, very clearly moving to the value model, yet we're at a time when new construction build in healthcare is at epic levels, right? Don't mean to use the word epic, but at all-time levels, right? So, I mean, is that just people lost in the old model, haven't made the transition yet, or how do you explain that?
Yeah, I think that's people responding to the current business model. And so we're caught right now in the fact that most of the business is still the volume business, and that's why the construction is there. But I would just remind you that Kodak discovered the digital camera, and I can just see that meeting that was happening every year. Now, you want me to stop selling film and go out and sell these little digital cameras, really? And I'm sure year after year they said, there's just no way. Yeah. There's no way. And we're right there right now, I think, in healthcare. And so you really need to be careful about your fixed investments. Because in healthcare, those investments are 50-year investments to amortize them.
Sure.
And I just think that this is a very precarious time to be making a lot of investment in those areas. But I think it reflects the reality of the current business model. What will make that either a good or bad decision is how fast the business transition happens.
Well, that being said, we recently opened a $1 billion new hospital.
Right.
So, but of course, in our neck of the woods, we do have earthquakes and other regulations and that are an issue. But I think as we take on more risk, as healthcare organizations become more like payers and become accountable for managing a population, I think that's going to really drive a de-emphasis on the inpatient side and really look at outpatient integration, all the things that you talked about that you've done so well in terms of community engagement and reaching outside the four walls of the hospital. That's really where the future investment is.
Yeah.
So let's move on to the topic of wearable medical devices. So I guess, I don't know what percentage of this room would have a fuel band or a Fitbit or some similar sort of technology, but I guess a fair amount of people, you seem to see them more commonplace these days. If you were to, gaze into your crystal ball, where are we 5-7 years from now about the types of technologies that will be kind of commonplace in the way that our, the smartphone is commonplace for us?
No tech meeting would be complete without, of course, this doesn't work for me, okay, until they actually do lenses.
Right.
This is useless. Plus, I'm blind in one eye, which means, so where the lens is located, this does me absolutely no good, but it's kind of cool to wear to meetings anyway. We're doing a lot of R&D in this space. with these devices as well as smartwatches and then sensors on the body. And it's an interesting sort of opportunity. I don't know where this is going to take us, but it's kind of the next generation of mobile, if you will. And,
Is that a clinical device or is it a patient device? You see it?
we're looking at both. So on the patient side, you can envision some use cases. Patients with dementia, Alzheimer's, could wear a device like this or other devices that are coming on the market. This could provide some cognitive aids, some information that they might need over time, allow them to communicate with caregivers in real time. And then the obvious use case, have you tried this? Here, I
did try it, actually.
So for a physician like you, we're doing a lot of work with taking information from the EMR.
Yeah.
And in context, you're walking around the hospital, and as you approach a patient room, we take that information from that patient, laboratory results, other sort of information, display it here in real time. So if you're doing rounding, you're not sitting here looking at a tablet, sitting in front of a computer, information's being presented in real time. And then in an academic center, we're working on sort of rounding apps, so you're doing rounding with students, you can share information across devices. So it really allows you to collaborate in a different way. And then for ambulatory visits, where we've really invested on the ambulatory side in EMR applications, encouraging physicians to do documentation for the visit. Now they're spending more time staring at a tablet than they are really interacting with a patient. So this sort of thing really lends itself to that. You can perhaps capture the visit electronically through video. You can talk through this using voice recognition and do charting that way as opposed to heads down on a computer. So the interaction with patients might be a lot richer with this sort of device in the future. Remains to be seen.
So this topalization of care, if you will.
Now, every meeting, now I'm from San Diego. Now, every meeting I go to, I hear Eric Topol. Of course, he used to be at Cleveland, right?
He used to be at Cleveland.
I used to work with him at University of Michigan before he went to Cleveland.
It's just my job to link the panel together. So,
so what's the topalization again?
So beyond glass, what are the other sort of wearable technologies we think will be commonplace? So we talked about, there's obviously the more basic devices, the Fitbits.
Well, I think the good thing that Eric has done is really encourage the VCs to invest in healthcare, emerging medical devices, wearable devices, sensor-based devices. And of course, he's out there promoting a lot of those, which is a good thing because it's drawn investment into our industry. But that's where I'm seeing most of the investment at this stage in the VC community, going into the idea that you're going to have wearable devices that can communicate with those for chronic disease management mainly.
Yeah.
What your view is on that?
Yeah, I think we're going to get a bimodal set of devices that come out. So I think there's this acute care thing. So if you have heart failure or significant medical disease, you will need these devices, which to me are consumer versions of medical appliances today going into the home. And I think they're likely to come a little bit faster because there may be a reimbursement model for them that exists today. But if you really think about where the opportunity is for us, it really is, in my mind, in the second investment scenario, which is in health, wellness, and behavioral change.
Right.
So when you really think about it, if you could focus in on nutrition, if you can focus in on exercise, and you have tools where you have actually built a reimbursement system that encourages that gives people real targets to shoot at, and then gives them an advantage for doing the right things. The ability to lower the cost curve is all in that coming stream, not in the correction of the people who are truly acutely ill. It's an appropriate application of technology, don't get me wrong, but I think the real hope in maintaining a solvent healthcare delivery system is in the ability to either delay the onset of serious disease or prevent it altogether. Right. So if you just take dialysis as one example, right. If you can delay the onset of dialysis by a decade, the lifetime expenditure difference is $1.75 million for one person.
Wow. That's incredible.
If you combine that with genomics on the front end, and that's an area that Eric is really focused on
sure.
and has been a leader in that space. Understanding your predisposition for a particular condition on the front end, which we've done a lot of work in that area in personal genomics, understanding your risk up front, and then programs to get you on the right track or to make sure that you're not really leading a bad lifestyle that might lead to a disease condition, I think is where the future goes. Hopefully up front as opposed, focus up front as opposed to on the back end after you already have a chronic disease condition.
This is kind of this notion that an engaged patient is like one of the best forms of medicine.
The problem we have is we don't have any financial incentives right now for any of this stuff. So all these startups that I talk to that are doing very innovative work are going to have trouble selling into the healthcare system. We're still making that transition from fee-for-service to global capitation. If we're under a global capitated model where we're responsible for covering a population, then we can eat some of the cost of these devices if it's ultimately going to reduce cost for us. But on a fee-for-service basis, the ROI doesn't make sense for a lot of these emerging medical devices.
So one of the things from a Juniper network sort of perspective that we are particularly interested in is these technologies, but it's the secure transmission of this information back to the clinical facility. I don't hear a lot of talk about that so much. They talk a lot about the importance of measuring the vitals, but how do you get it back securely to the facility? You mentioned you had a concern in your use case example where you had somebody, this patient, I think it was John in Southwest. Say again? Arizona. There you go. Who he wasn't part of. He chose to populate his record independently, so therefore you weren't necessarily going to fall foul of HIPAA regulation. To what degree is secure transmission a concern?
Well, I think it's probably the same concern that any industry has, and in my mind right now, we're getting pretty good in encrypting data in motion, is what I would say. So when we pick it up and transmit it out onto the internet, most of the transactions that we're doing today are encrypted. Where we have real challenges is when it's at rest. So in the entire EHR, the idea that we would encrypt everything and then take it apart just when I want to look at it, I'm waiting to see that day.
Right.
I think it's a great idea. I think we have to get there, but it's a challenge.
But what about this data that's going to live in a patient home?
So I think you're going to see it. I mean, I'm amazed at how many of these glucometers already have encryption.
They have some encryption
models built right into them. So I think they'll come ready to go. But again, I still think it's the idea that when it gets wherever it's going is where I see the biggest risk at this point.
I don't know what you're worried about. The NSA already knows everything about it. All you got to do is search Facebook and
So I think at this stage, I'd like to open the questions out to the audience. Just a few questions.
Right.
So we have microphones on both sides aisles here. So there you go.
Hello, very interesting talk. My name is Larry Wellickson. I'm an internist, and I'm the CEO of the Society of Hospital Medicine, which represents the 40,000 hospitalists around the country. Whenever I think of technology, I always worry about the legacy systems. And I will tell you the two biggest legacy systems are the existing physicians in practice.
You said that, I didn't.
right on the mark.
And the academic medical centers that are training them, or not training them for the 19th century, not the 21st century. And what you've posited is this enormous information flow and you would have to rechange the process of what a doctor believes his job is. because the only way this works is you have to spend part of your day, maybe a third of your day, actually seeing patients, and 2/3 of your day analyzing information on the patients you see. I know a lot of the doctors at Cleveland Clinic. How successful have you been? Because having all that information lying around and nobody looking at it, you might as well not have it.
Yeah.
So how are you doing?
Yeah, so it's a great model. So this to me is the next great opportunity that we haven't talked about. And so I'll tell you something that's hot off the press right now for us. It is changing to that paradigm of converting the physician to primarily a knowledge worker if you're not a proceduralist. Right? So what I will tell you is that we actually had an advantage at the Cleveland Clinic because we do a lot of procedures, and so this technology allows us to set up those procedures, and it makes it very efficient. But in the places where there's far more cognitive work that's going on, you have to do something that's fundamentally different to get the value out of the technology. So I'll give you an example. I'm going to use our hip and knee replacement. So we've now built a model that is what we call a care path model. And we've heard about them, and you'll see paper versions of them, and they kind of sound like guidelines. But this is, I think, the 21st century version of it. So first of all, it's predicated on all those tools being in place that I talked about. So you've got to build on top of it. The second is what we did was to put all those physicians in the room, all of the surgeons for hip and knee, the physical therapists, the SNF individuals, all together, and we said, now let's take and write out this guideline. We started with a little model, and we had them build it out. Once we understood how it was going to flow, we said, okay, now let's think about how the practice should work going forward. So the key to this thing was it literally changed the way we think about the practice and who does what when. And if you don't get that right, then you're absolutely right. What you're really doing is putting in brand new technology, and you're going to drive to the exact same model that you have today. So in this model, we began with the patient's part of the scenario. So today, if you're coming in, and we suspect, because we won't know at the time of the first visit, that you're coming in for hip replacement, at the time the appointment schedule is made, that request is recorded, and the computer sends an email out to that patient and has them go through, and they enter their activities of daily living and their functional status assessment. Now, with that being done, the physicians look at that before the patient ever comes in a work queue that happens prior to the day of the visit. So if you know orthopedic surgeons, they like to batch schedule, right? So they schedule everyone for 1 o'clock, and I'll see them all before 5, right, is the model. Well, if in fact you have this information available, you can sort them out into groups up front, and that's what they're doing with their nurse practitioners. So they're sorting them out to groups and rethinking the way they're going to actually see the patients in the office. So that's been a very powerful tool, and it changes the way they think. The second is for those who are clearly headed for the hip replacement, they've now leveraged the nurse practitioner to practice at the top of their license. So they're doing all the things that they would have normally done per the protocol, and they are simply sitting back and doing the evaluation portion, walking into the exam room to confirm instead of the other way around. So you're absolutely right. I think this for us is the next transition. I see about 30 diagnoses that will fundamentally change the way the typical subspecialist works at the Cleveland Clinic going forward. So you have to do it all. You have to have the tools. You have to rethink your processes. And then you have to be data-driven if you're going to get the model change that's necessary.
Good evening, and thank you again for being here today. Excellent conversation. My name is Carlos Amaya. I'm a senior manager with Deloitte, and I work in our technology risk advisory practice. And a question that I would ask is, what were some of the challenges in the cultural transformation both on the clinical side as well as the patient side, in going to this fully integrated model?
Yeah.
And what would you say, let's say, to an aspiring hospital system that is looking to get into this fully integrated model, transition into an accountable care organization, and it's probably at an early stage of getting into that process?
Yeah, so I would say, one, this is really change management, transformation work, and over the course of the decade, I think we've seen differing challenges depending where we were on that. So early on, I will tell you, we were literally introducing technology going directly from paper. We did not have a prior computer system other than a basic results reporting system. So the first big challenge was the introduction of technology into the practice. It was huge. It took a lot of at-the-elbow conversations with physicians, and then it took the steady removal of paper from the process in order to get over that first hurdle. I think the second one then was also moving the patients along. And so I can remember when we brought up the personal health record, the MyChart tool, which today I think the average person, as we can see by the sign-up numbers, kind of expects. They get it at the bank, they get it at the airline, and they kind of expect it. When we put that up the first time, I got a fair number of nasty grams from patients calling in saying, how dare you ever make that available over the internet? Now we never hear that question. So we absolutely had to bring the patients along about why these tools would make a difference. And so what I would say to you is, I think one of the big things you need to do in any change management program is you have to communicate the why, and you have to communicate the when. And you have to get those two things at the right time, or else it's going to be very difficult. People are going to be reacting to something that happened to them, and they'll be uninformed when they have that reaction, and you're not likely to have a constructive conversation with them.
And the way to change physician behavior is either with a big stick or a pile of money. Mm-hmm. He's like, am I right? There he is. See, I was told they were taping this, so I was like, "This."
You wanted to make
I'm going to
news, too.
regret all of this at some point. All right.
Hi, my name is Evangeline. I'm also from San Diego. Dr. Harris, you mentioned the my monitoring tool earlier, right? So as you know, chronic diseases, they're a major contributor to the healthcare cost here. And chronic diseases, if they were managed well, the patients would not end up in the hospitals requiring those very onerous and expensive procedures, which is the main source of income or revenue for hospitals, right? So, but the thing is, I saw you presented two versions here. One is the high end and one is the low end. But as a physician, I don't need data, I need information. And data doesn't equate information in that sense. Mainly there are 2 points. One is like you and I can suffer from the same condition, right? We can have totally different symptoms. But even if we have the same symptoms, a symptom that matters to me more might be just meaningless to you because we have totally different personal baselines, right? And secondly, chronic diseases, they have a lot of acute symptoms. And I cannot just look at a snapshot at a period of time and say, hey, Dr. Harris, you're having a minor stroke. I have to, it's a time series problem, it's not a discrete problem, right? So I have to tap into your medical history record, your family history, build some trending and profiling before I can say, well, you really have a problem here, right? So all in all, I think, you need meaningful information versus a bunch of biometric data being pumped out from those like consumerization type of gadgets, right? And you need, as a physician, I need actionable intelligence. I need something that can provide me clinical inference or even correlation. When we think about like comorbidity, right? I cannot just look at a single silo set of variables related to my diabetes I might have to tap into. I might have a congestive heart failure going on at the same time, so I have to correlate those two sets of data, right? So I see a lot of trends and fads out there when it comes to consumerization of healthcare, but I don't see anybody or a lot of solutions out there addressing that end of the spectrum. Yeah. So can you give us some insights or?
Sure. I think what you're really speaking to is that just taking in a tool and applying it to the entire population isn't going to solve problems for you. It's just going to generate a lot of data. On the other hand, there are very simple data points that make an enormous difference. So let me give you an example. It would be heart failure. If you want to predict a patient who's actually going to come back into the hospital as a result of decompensated heart failure, there's one vital sign you absolutely need. It's the weight. And if you get that weight, now I didn't say every single patient, you're never going to fix every single patient, but I will tell you on a statistical basis, if you watch the weight go over 4 pounds in 4 days, that is the patient you should target your resources on in order to get them managed properly. Yeah.
Okay, so just one more. So when it comes to HIE, right, we make several attempts in the past, back in the late 90s. There's one in Indiana, there's one here, right, in Santa Barbara, right? So they were flops. So why do you think now is the time? Why do you think it would make it this time around?
So I don't think we have a choice. That if we don't get to interoperability, then you can't transform the healthcare system over time efficiently. So I think the difference is we're in a different age with technology. I think that we will have more technology deployed. If you really go back to the early Indiana projects, they were really just working with those institutions that actually even had an EMR at the time. So the ability to drive interoperability, to build a business case was pretty small because you had a limited number of people who could actually use it. I think in this point in time, like I said, by 2018, I fully expect 85% of the facilities to be in place, and they will need this solution. So I think the marketplace will drive it.
Yes. I firmly believe that if we're ever going to get the cost of healthcare under control, the first thing we have to do is improve wellness, because I truly believe that wellness drives health. Now, you mentioned a couple of things, Dr. Harris. First is that you've created these best practices for physicians so that they can execute better. And so could we not introduce best practices for wellness as well? And you talked about increasingly how your clinic is reaching out to the world. Could you be a center of wellness as well as a center of health and give best practices to your people so maybe they don't have to go see you for many, many years?
Yeah. So I love the model. So we have actually as a department chair a chief wellness officer. Physician leads the department. He runs a program that you can, this is not a commercial, but if you wanted to see it, where you can go sign up right now and you will get a tip of the day delivered to you, which is focused directly on that wellness model. Now, I would tell you, I think that's still a broad brush, and that it needs to be part of a more comprehensive program going forward. But I absolutely think that is the model that you're going to see. But my goal is, and this was a point I was going to make earlier, we're still thinking about it as if we're using the medical disease model. My goal is, at the end of the day, this will happen not because you think you're in a wellness program, but because you're simply living out the activities of your normal daily life. It's truly incorporated. It's not in the side. And by doing the things that you just think you need to do to have a good day, you are also doing the things that really drive wellness going forward. And I think that's where we have the opportunity. If we match it to the right technology and you introduce it for the right reasons, it won't be about medicine. It'll be about having a good time.
Hi, Dean Chan from Windover Systems and Intel. Just to dive deeply into just one thin slice of this whole connected and very impressive health system of the Cleveland Clinic, could you talk a little bit more about success stories and failures in the use of machine or sensor data to drive clinical decision making? So you mentioned weight as one signal. I know Sutter and Stanford and even Aetna are doing stuff with congestive heart failure. Could you talk through a couple sort of use cases, ones that were home runs, ones which fell flat for various reasons, and how the technology industry might be able to kind of provide solutions that help that type of use case along, machine data for clinical decision making?
Yeah, so, probably when I think about real sensor data today and where it's making a difference, it's not in my sweet spot, but I see it where you're actually using the data from the sensor to drive clinical decision making, still very up at the high end. So we see it in these very complicated endovascular replacements where you're trying to decide whether or not what kind of replacement to put in for an aortic artery. And so normally when you do that, you're going to introduce a lot of sensors into that patient before you do the replacement in order to decide what to do. So it's a very powerful model. I frankly think they couldn't do it now without a sensor. So that's a high-end use case, but it's very, very, very specific. There are a couple intracranial ideas that are built around that same model. I can honestly say on the ambulatory side that I've seen a lot of use cases for that high-end a sensor. And that's why I'm saying we ought to crawl, walk, run. I do think there are some basic things, weight, blood pressure cuff, those things that if we build those into algorithms, we're going to get an enormous value from them without having to buy the really sophisticated kind of technology that you're talking about. And we should target that for the areas that where we need it. I'm just not sure I know where that is yet.
Hi, my name is Dr. Gianulli. I'm with a company called Cario in the area here in Irvine. And Cario is a SaaS-based electronic medical record and practice management system vendor. We have something like 5,000 docs using our technology today for EHRs. One of the problems we face every day is the challenge of communicating information, data exchange. Now, there's a technology that's been developed over the past several years that's pretty uniform called in-hand direct or directed exchange. We can leverage that very easily between our many small practices and the points of communication such as Cleveland. The problem we have, however, is that on behalf of the small doctors, they can intercommunicate great. We go to a large institution, we don't have visibility into their directory, nor can we actually exchange messages very easily because we don't have that trust association with the larger enterprises. So how can that get solved? What's your view or perspective on solving that, and is that one of the technologies you're looking to integrate?
Yeah, actually it was, that was a slightly old slide, so it said in-HIN, but that's really the in-win technology. So I absolutely see it as an opportunity. Now I can tell you in my market, we'll probably be the first large system to go up on that in a trusted way. We're prepared to do it. I think the dilemma is it's going to deliver very little value to us initially. That there are some smaller practices that are using it already, but when you look at the other large health systems, they're just not there. So I see we're going to do the right thing, but we're going to get very little value for it. And that's why I'm saying it's not clear to me which one of these solutions will work, and so we have a bet in each of the camps right now.
So we've set up a HISP for our organization and our catchment area, and then we do direct protocol transactions from the healthcare system out to community independent physicians, and then allow them to join a HISP if they want to subscribe to a HISP, and can receive messages and can kind of leverage a shared service model. And that works very well, as you said. So direct is this lightweight point-to-point communications protocol. There's an emerging standard that we stood up for directory services that allows you to create a federated sort of directory model, and that's worked very well. But that is not a fully baked standard, and I forgot the acronym, HSPA or something like that. You may know what it is, but that's sort of an emerging standard in the directory space relative to direct.
Hi, I'm Brady Davis. I run the Oracle Health Innovation Strategy Division, and I'm curious, actually, this is kind of trying to create a conversation between the two of you, to be honest. So coming from an innovation perspective, you said something earlier that was, I think, very appropriate, and that is that smaller startup companies have a very hard time getting into the healthcare system relative to the fact that, they need to try and drive revenue, and it's hard. So one is, how do you create that ecosystem, like a sandbox, to play in for these startup type of organizations? Cleveland Clinic would be a perfect example of one that could hopefully prove out a concept that could be fairly credible in nature to drive that innovation outside of those doors into others. Second would be, you brought up something that had to do with also, well, you talked about being kind of that incentive financially. So if you look at, I believe it was Cleveland, there's others that are doing it, Virginia Mason, Mayo, partnering up with Walmart and doing some specific payment structures around heart disease. So when you start to think about that and you look at it from the concept of, is it possible that Cleveland can actually become a payer? So if you're structuralizing some of that around ACO and pay for performance and things, and then could join that, if you will, with innovators, how do you create that true sandbox of innovation that drives incentives financially to really accelerate?
So this is an hour sort of discussion. So I'm an innovation officer with a healthcare system. Maybe at best you can count on one hand the number of chief innovation officers there are among healthcare organizations around the country. So I am not in the IT department. We have a CIO. I report to the CEO. I'm the equal opportunity disruptor, if you will. And I have an API for dealing with startups. And, I talk to any number of startups a week, and about, what they're doing. And I bring them in. We've got a sandbox environment. We've done a lot of work with startups in the regulated space and taken them through FDA approval. And it's something that I encourage hospital organizations to do, is to set up that sort of environment. The challenge today is we don't have many healthcare organizations outside of the handful of top academic centers that are accustomed to that, doing that sort of work. And so the challenge for startups is really how to engage, what's the API, the handshake, with a healthcare organization that's interested in innovating. And I wish there were more of those healthcare organizations out there to really get some of these concepts that are being invested in and see whether they could be translated into the real-world practice of medicine. But the other thing, what was the other question? Multi-part?
The multi-part of it was around, from an incentive perspective, I think the Cleveland Clinics of the world actually have the potential to become like a group health or a Geisinger, where you see all these systems that can become a payer.
Yeah.
Also, that's creating that incentive that says, hey, if you're an innovator and you can bring in a product and a solution that can help me improve quality, reduce costs.
That's the connection. So I think we're in a transition period, too, around innovation in medicine. Now, historically, remember, it wasn't around health information technology. It was really around medical devices. And if you think about the investments that were made, there was more margin in healthcare to allow the investment to come from the facility out. So, and there was direct professional interest in developing that next new hip or the next new pacemaker, because it really progressed the profession and the professional experience of the physician investigators many times. I think the dilemma we have now is the margin in healthcare is going away. And so the challenge is when a small company comes in today, the idea that we would actually just try it on a lark and see if it goes somewhere, that luxury is gone. So what I would say to you is it's not so much tied to whether the provider is a payer, but whether or not you can get a provider and a payer together to invest in that model.
That's a challenge.
That's right, but But I think it's the challenge that's the accelerator.
Yeah.
If you do it, because they're looking for it.
Yeah.
Remember, that's the tie that binds those two together.
Does anybody here work for Kaiser? There. So I'm convinced that when our friends in Washington sat down and developed the model of the future, it's Kaiser. It's a fully integrated plan at risk for a population with ambulatory, inpatient, group physicians that are completely aligned. I mean, that's the model. So, why fight it? You're going to become Kaiser. You're going to academic Kaiser.
Hi, my name is Sudesh, and I work for Beckman Coulter. I represent the informatics products. Every time I go talk to a CIO, they're looking at information systems products as a cost avoidance opportunity and as a quality of service improver, never as a revenue generator. Mm-hmm. So always, I'm looking at how can I improve your bottom line, never about your top line. Mm-hmm. When will you think you can use informatics as a top line driver and as an opportunity for doing M&A? Why would you have a better chance of acquiring a hospital over Guy Singer? Because you have a better IT system, and hospitals would sell them to you as opposed to selling to somebody else.
Yeah, I love it.
Question.
So I love this question. So the answer is I think that opportunity is right now. And I didn't spend a lot of time talking about it, but the My Consult program for us is a revenue driver. That program is built on a web-based expression of our physicians' professional opinions, but it's delivered to patients in 91 countries. They pay with a credit card in order to get that professional opinion, and we give it to them. And I can tell you what's really impressive is the original diagnosis has been accurate. We've found now certainly in North America, upwards 85% plus. It spreads depending on where you go around the world. What's different is the treatment plan. That accuracy is more like 60%. Now, a big piece of it relates to the diffusion of new technology and new treatment plans. So many of those new treatment plans happen at academic medical centers, and then they diffuse into the rest of the healthcare system over, depending on what it is, 5 to 10 years going forward. But what I would tell you is we absolutely see it as a top-line generator. Okay. Now, so that's kind of one model. I think the other one you're hitting right now, I think you're going to find that people who can demonstrate capability in HIT are going to be very attractive when people are thinking about merger and acquisition opportunities. That's what I meant by scaling. So if I'm a healthcare system that's doing fine today, but I know I'm in the volume world and I have to get to the value world, I'm either going to put all that investment into HIT, or I'm going to find a partner who's already there. And then in the merger, I go, well, I would have invested this $100 million. I will not do that. As a result of the merger, I will leverage that investment, and the $75 million that's left over will go put into new program development going forward. I absolutely see it as a differentiator.
So, alas, I think we're coming. We have one more time question for one more. Okay.
Hi, my name is Dov Gal. I'm a clinical and regulatory consultant for the medical device industry. And I wanted to ask you a question to follow up on a comment that you made about wellness. So this conversation, the topic is healthcare. Healthcare and wellness are two parallel universes that are not connected right now. And in a utopian or aspirational world, I see wellness taking the bigger chunk and healthcare being, at the end of the road, taking care of patients. What does the Cleveland Clinic do in order to get there?
Yeah, so the first thing I'd say is you have to eat your own cooking. So if you believe that story, then you should be willing to invest in it. And that's exactly what we've done. So although we are not an insurance plan, we are for our own employees. So we represent about 100,000 people that we care for through our own insurance plan. So over time, we've made progressive investments in health and wellness. So the sort of really basic ones have been focused around smoking, because of its sort of broad effects and direct benefits going forward. So we initially began with investing in smoking cessation programs for all of our existing employees. We then said to anyone who was applying to the Cleveland Clinic, you would be tested, but if you failed the test because you're a smoker, we'll invest in you to quit smoking. And then 90 days later, you can come back and apply. We won't hold the job, but you can come back and apply, and if you're not a smoker, we'd be happy to hire you. So that's sort of basic things going forward. Now, we then turned that around and said, okay, now let's think about what are the big things that affect our employees and their wellness, if you will. And so we focused in on nutrition and weight. So we have dedicated nutrition programs that help you eat healthier, and our Chief Wellness Officer is really responsible for that. It's about thinking about eating as part of your normal life, not how do I prepare this special meal over here that I'm just going to hate. Right? That's not going to get you there. It's a lifestyle change. It's a way of investing in those kinds of things. And then the other is we made large investments up front in managing weight. So we offer, you name the program, we probably offer it to our employees for free. Weight Watchers, whatever, the local gym, you name it, we pay for those things for our employees. So the goal for us is to demonstrate, and we are now beginning to see it, I think you're going to see very shortly, we are bending the cost curve for our own employees. So I think that's the evidence that you have to be prepared to do it yourself, and then you need to translate that into the general population go forward. I think that translation into the general population, though, is going to come through some insurance program over time that provides that same incentive to the individual.
So, first of all, thank you so much for a fascinating panel discussion, a fascinating keynote presentation. I guess I get the honor of the closing question. So tell me something that will surprise us about how healthcare is going to be delivered in, say, 10 years. Like, what can we expect to see? So let me give you a couple. So one, obviously, we're talking about Google Glass. But when I think about General Electric and how they've got thousands and thousands of sensors that are being monitored in real time, 24/7, you can easily think about a world. Oh, and the business model's completely changed, where they now charge you kind of a very different pricing model. It's an annual fee rather than, actually maintenance and so on. And they charge you for the time the engine is in flight rather than an engine is actually being used, whether it's on the ground or not. You can easily think about all these sensors that we hear about, especially if you hang around San Diego as much as some of us do, with all the wireless devices that are being, everything from Sotera to whatever, we could be wired all the time. So do you see something significantly different? And, I think Ryan asked that question early on as well. So maybe we minimize the amount of time we go to the physicians because all this, the wellness and the illness part is actually captured in real time. And I think about my mother-in-law who passed, and she wore this. Weight was the problem, and she kind of wore this device where you sent a cardiac device where you sent your data to you actually to push a button once every 3 months. Mm-hmm. Right? Those days are long gone, hopefully. But just tell us something that will surprise us about the way we will receive medical care in, say, 10 years.
Well, I think you cited the obvious ones, right? The sensor stuff. But I think what's going to be surprising to a lot of people is the financial model is going to change. And it has to, for us to be able to deliver next generation care. And the way we're funding care today on largely a fee-for-service basis, that's where the innovation needs to happen, I think. Incentives that drive the adoption of wellness, population health, sensor-based care, genomics, to be able to fund all of that is really where the innovation needs to take place.
Yeah, I would say, I think it's the experience that the whole conceptualization of what care means will be fundamentally different. And I think you will also be surprised at how much people are willing to engage with technology that is enabled, knowledgeable, and can communicate what they need when they need it and in the right location. that the whole experience will not be one where I start to think about it when I'm sick and I go somewhere in order to have something done. I think that experience is going to be an experience that is really focused around what do I need to know and when, and how do I actually incorporate it into my daily life.
The background analytics that we're going to put in place to analyze all this information. You asked a very good question, which is most of these EMRs are nothing but dumb sort of electronic filing cabinets. And so that analytics that can offer you a differential diagnosis in real time based on evidence in the literature that's presented to the clinician in real time at the bedside or in the ambulatory setting, I think is where we're going to start to go.
So I think one surprise and one, I guess, prediction, if you will. I guess the surprise will be, in spite of the very poisoned political climate we have today, we will get there. I'm absolutely convinced of that.
We're 3 shutdowns away from a fix.
But we will get there. 10 years from now, we will have arrived.
Yeah, but only one default.
There's a one default, yeah.
We hope. And I think the second thing is, I think it's really interesting to see the big game changers wading into this space. So Google clearly are doing that. The rumors are rife about what Apple's doing, but when they come into this space, they will make a huge impact. So the game changers will make these technologies becoming part of our everyday life. I think that will be very considerable.